presentation. We'll go to the next, Dr. Sushmita. So Dr. Sushmita is going to tell you how to do trabeculectomy for a successful outcome.
So at the outset, thank you very much, Dr. Pandav sir and AIOS for the opportunity. So trabeculectomy is still our savior, and it saves vision because the vast majority of our patients come with advanced disease, they're poor, and they're unable to afford medications. And despite all the tom-tomming of the MIGs that we see around us, I think it's very, very important for every one of us to know how to do a good trabeculectomy, because believe me, that will save vision. So this is a patient I've pulled out, somebody who came to us almost about 10 years ago, and he presents, so these are what patients present as. Split fixation, 10-2 fields almost gone, 0.9 cups, and the OCT is completely gone. So nothing but a trabeculectomy is going to work. And this is 9 years after a phaco-trab in both eyes. And you can see these are the pictures, the visual fields when he came to us, and these are visual fields now. So pretty much we've been able to preserve whatever vision he has. The pressures are fine and the fields are stable. So at the end of the day, when we're really doing glaucoma, it's about preserving and saving whatever vision that the patient came to us with. So the success, as we've seen, depends on preoperative, surgical procedure, and post-op nurturing of the bleb. I'll be dealing with the preoperative and the surgical procedure, and the post-op nurturing, I think sir will take on. So in the pre-op considerations, we'll touch upon to assess ocular surface and conjunctiva, avoid anticoagulants, lower the pressures before entering the eye, and a mannitol pre-op for vitreous detergents. And during surgery, it's nice for adequate exposure, minimize bleeding, careful dissection, adequate size and thickness of the scleral flap, that's important, and iridectomy to encompass the sclerectomy, no intraop hypotony at all, reasonably tight closure of the scleral flap with releasable sutures, and a watertight conjunctival closure. So this, in a nutshell, would be what your pre-op and intraop would be. So let's look at them a little more carefully. So we need to assess the ocular surface, the lids, adnexa, conjunctiva. It's nice to give topical steroids a week prior, because all of them have been on multiple anti-glaucoma medications usually, and it's a very inflamed sort of surface. Reduce the IOP before surgery, stop anticoagulants, and of course assess the general health. So eye on the right, if you're going to go in straight away, it's going to be very difficult to control the pressures with the trab, whereas I would like to operate with the eye on the left after a short course of 10 to 15 days of steroids and make it quiet and then go in. Another way to look at this is to assess the conjunctiva. You can see we are really going down and seeing the movement of the conjunctiva under the sclera. It gives you an idea of whether it's mobile or whether there has been already subconjunctival fibrosis. When you know, probably you can up the dose of your anti-fibrotics if you do that. The other thing is an adequate exposure and conjunctival flap. So these are just small clips which will go on. This is a corneal traction suture, which we usually use. We have to have an adequate exposure no matter what. There is also an ong speculum, which is on the lower side, and you can see you don't need sutures then. It has a larger inferior blade, which just pulls the eye down, and you can see that there is adequate exposure. The next thing to do, of course, is to have a conjunctival flap. The phonics base needs lesser dissection, so we've all shifted to a phonics based. I'll just move this forward. Yeah, so we've all shifted to a phonics base rather than a limbus base, simply because the dissection required is lesser, and we have adequate space to make the scleral flap. We avoid cutting the tenons because that causes a lot of bleeding, so you'll see most of us usually push the tenons away, which makes it better. The next, of course, is to make your partial thickness scleral flap and mitomycin. So it's nice to cauterize the bleeders, just lightly. Be sure that you're not going in with a bleeding subconjunctival space, because that will make it more difficult. Whether you do a triangular or a rectangular flap is a matter of surgeon's choice. Ultimately, it doesn't matter. What matters is you need to dissect at least 2 millimeters into the cornea, so that when we make the incision, we are sure that to include the limbus. MMC, this is Penghor's technique. We put it right away at the phonics and see that the edge of the conjunctiva is not used. 0.2 to 0.4 milligram per ml for 2 to 4 minutes, depending on the case, and it's put right up there, and wide application in the fornix, avoiding the limbus, which we think by avoiding the limbal stem cells, you have lesser incidence of cystic blebs. The next would be a paracentesis and sclerostomy. So the interesting thing about paracentesis for a trab would be that it's a long tunnel and usually parallel to the limbus rather than go straight in, and that is especially important for phakic eyes to avoid injury to the lens. We usually do give pilocarpine to constrict the pupil and put in a bit of viscoelastic to avoid the hypotony. Coming to the sclerostomy, you can use either. This is just using, sometimes you don't have a punch if you have 2 or 3 glaucoma surgeons in the same OR. So using scissors and Avana scissors is fine as long as your iridectomy is covering the entire sclerostomy so that there is no block later. The scleral flap closure usually is with releasable sutures, so you can use any technique. The idea is to have a tight closure so that the inflamed aqueous does not go out into the subtenon space in the early period. You don't mind the pressures being in your higher teens just for about a week or so. And there can be any technique to do the ong. I like to do the shoelace pattern, but any technique to do the releasable sutures as long as you have a bite or a loop on the cornea, which you can take out at the slit lamp postoperatively. Then, of course, you need a watertight conjunctival closure. That is the most important part. You have to avoid leaks on any end. There are different techniques as for all surgeries, but the closure has to be tight. It can be continuous, it can be wing suture. So this is a wing suture in which you have to be sure that you include the ocular coat, a partly ocular coat with it. So the needle here would be a spatulated atovicryl, whereas a limbal suture we usually use a round-bodied atovicryl. So we also tend to, with the fornix-based flap, we tend to override the cornea a little bit because there's a little bit of retraction always, and then there is no chance of a limbus exposure. So to summarize, trabeculectomy is a long journey. It starts much before surgery. Judicious preoperative planning and meticulous surgery are the special cares to be taken, and basically avoid hypotony, use antimetabolites, and ensure tight closure at the end of surgery. Thank you for you.
Thank you, Dr. Sushmita. Any questions? So we have time for questions. If you have any, I think we can take them. I think when you're doing the important thing is, from again, why the blebs fail, basically, there are a couple of things. For healing process, you need to have the normal milieu, and that means that your circulation, your nutrition to the tissue should come, should be normal. And because we are doing a lot of cutting there, so we are cutting the vessels, and we are also coagulating the vessels, and we are using mitomycin C on top of it. So what it does is that it actually destroys all the vessels in that area. And most of the time we are thinking in terms of blood vessels, the capillaries, but there are lymphatics as well, and we know there's a lot of work available already there. So we are destroying everything. Now, if you are throwing a lot of fluid into the subconjunctival space, the fluid has to go somewhere. It has to be drained by something. And what we do is that we remove all the draining channels. We are we are cutting down all the draining channels, throwing a lot of fluid there, and hoping that this fluid will be taken care of, by some magic. And surprisingly, that magic happens 80% of the time. It works 80% of the time, or let's say 70% of the time. But overall, that's not a normal situation. So the wound, they keep on modulating later on. And that's the reason, because you haven't actually restored the normal physiology. So that physiology is still abnormal, and that's why these wounds, they keep on kind of smoldering, and failure after 1 year, 2 years, 3 years is known. And if you look at the failure rate of TRAB, between 2 to 3 years, 30, 40 of them will fail overall. 30, 40% will fail overall. Again, it depends on each patient, so there would be some higher risk and there will be some normal risk patients for failure. I think we'll continue that discussion, but before that, let's have a look look at the risks, the factors that could lead to the failure of the trabeculectomy. And then I really also appreciate your own thoughts, how this process of healing and or the success of TRAB happens. Yes, please, there's a question.
Sir, I had a question for ma'am. What is the ideal time to release the releasable suture? Because I've noticed after 3 to 4 weeks when I try to release my sutures, it often breaks off and I cannot get it out. Either it is very tight and it is not coming, or is it healing within the layers of the conjunctiva and tenons? I'm not sure.
Yeah, so I don't think anything before 5 to 7 days is of any use if you're putting a releasable, provided of course you've put it tight enough. And but after 14 days, it's a little dicey. But with MMC, we can go up to 3 weeks, but usually after that, it just gets, stuck in the fibrosis. So if you need to take it out, it needs to be before that. After that, if you need to, there has to be, maybe you can do a laser suturolysis. If you have that, you just need a 532 laser to do that. But yeah, you're right. By the time it's 4 weeks, it usually gets stuck and it breaks. Then you have to do something else. But if you want to release it, by 7 to 14 days is the ideal time.
Thank you, ma'am.
I think my thought on releasable suture is like, it helps you, reduce the fluid overload of the tissue right in the beginning. So if you have made them tight and there's not much of fluid going into the space, if that conjunctiva is dry on the first or second day post-operative, that's actually a good situation, because then within 48 to 72 hours, you have enough healing to keep that fluid that bleb from leaking. And then on third or fourth day, you form the bleb. And the bleb can be formed by bleb massage or just a little muscular depression around the bleb without releasing the suture at that point of time. But if some fluid is already going into that subconjunctival space, then you don't have to do basically anything. And then you just have to monitor the bleb. And the monitoring of the bleb would mean that you monitor the height, you monitor the IOP, you monitor the extent of the bleb, and also the vascularization that is happening in that bleb. And your release should somehow be, there's no perfect way of doing it, but I think that can be timed with that. Very often we actually time our release with the IOP increase, but that's good, but I think there are other factors also that we should keep in mind before we decide whether we really want to take out or at what point of time we want to release the sutures. 7 to 14 days is the usual window that we have for releasing the sutures, but I think you have to adjust that according to each case.